Welcome everyone to Transparency and Coverage. Where are we now? Thank you all for joining us. Our moderator for today's call is Jill Brooking. She'll be answering the questions you sent through the Q&A today. We will try our best to answer all of your questions, but if for whatever reason we are unable to get to your question today, please follow up with your advisor for further assistance. Today's presentation is being recorded. We will be sharing the recordings in the follow-up email and on the NFP website. If there are any portions of this call that you missed, by Monday, you will receive an email with a link to the full recording. The PowerPoint slides used during this presentation will be shared in the same email. At this time, I'd like to introduce our speakers for today's webinar. Joining us today are Carol Wood, Vice President and Counsel of Benefits Compliance at NFP, and Lori Fischler, Vice President and Counsel of Benefits Compliance at NFP. We're very excited to have them speaking with us today. It is my pleasure to hand over the call to our speaker. Lori, the floor is yours.
Thank you, Amber. And Amber, I'm going to ask if either you or Carol could take over the movement of the slides. My keyboard just seemed to freeze up and I'm not able to control it. Thank you, Amber. Thank you so much. Sorry about that, everyone. A little technical difficulty on my bad. I apologize. Thank you for joining us today for this month's Get Wise Wednesday training. It's a pleasure to be here with you. We have a lot to cover, so I want to get started. But before we do, short disclaimer. Today's information is intended to be used for, is intended to be used for general guidance purposes only. It is not intended to constitute tax or legal advice. And of course, any questions of application of the law should be addressed to legal or tax counsel. And of course, today's information is current as of today's date, November 16th. We do have a packed agenda, but before we get started, I'd like to ask that everyone hold their questions. Carol and I will do our best to save enough time at the end of the presentation to address any questions you have. Of course, having said that, feel free to submit questions in the chat at the bottom of your screen. We do have our colleagues and compliance consultants ready to answer questions throughout the presentation. Again, packed agenda. We're going to primarily be covering two transparency-related rules for you today. That is the Transparency and Coverage Final Rule that was finalized in 2020, and it deals with the ever so popular MRF, otherwise known as machine-readable files, that we all became familiar with this past summer, and the ever so anticipated Internet self-service tool that we are looking forward to in 2023. We're also going to cover the Consolidated Appropriations Act of 2021 with you, otherwise referred to as the CAA. And the CAA, while originally passed to deal with concerns around COVID, did, interestingly enough, include provisions that directly impact employer group health plans, such as the No Surprises Act and other various transparency provisions. For each topic, we will review the specific requirements and discuss current status and recent developments and provide insights as to employer considerations going forward. So with that, let's get started. When Carol and I first met a few weeks ago and talked about how we'd like to present these topics to you, we thought it might be helpful and beneficial if we took you guys back in time and thought about why these federal laws were enacted to begin with. It might help put the conversation into better context. Well, for starters, we all know that legislatures have long been concerned about rising healthcare costs and just a general lack of price transparency. In addition, there's been strong bipartisan support for quite some time around protecting participants from surprise medical bills for unexpected out-of-network services. I don't think it'll come as a surprise to any of us on this call that medical debts are a leading cause of financial distress and bankruptcy in this country. And finally, there really has never been any comprehensive federal measures on the books to address these issues on any sort of significant national level. And as a result, states have enacted a varied mismatch and patchwork of inconsistent state laws that have been difficult to implement and manage. So as a result, our government responded in 2020, or at least beginning in 2020, really as a promulgation of the ACA, and released the final rule the Transparency and Coverage Final Rule. Again, this was released by 3 departments, the HHS, DOL, and Treasury Department. It applies to non-grandfathered group health plans. And it primarily mandates the public posting of those machine-readable files that we dealt with this last summer. It also requires plans to develop an internet self-service tool that kicks in January of 2023 for the 500 most common items and services. We will dig a little bit more into those details later on in the presentation. In addition to the Transparency and Coverage Rule, the following year, Congress acted and passed the Consolidated Appropriations Act. Again, originally designed to address concerns around COVID, it did include a couple of provisions that directly impact group health plans. Title I, the No Surprise Act, and Title II, transparency provisions, which includes numerous requirements with varying enforcement dates. In short, these laws were intended to push us towards greater transparency in the industry, to remove confusion and complexity from our healthcare system. I guess overall, the goal here is just to empower consumers and making and providing them with more informed data so that they can better drive their own healthcare decisions. So how do these new laws directly impact your health plans? Well, there's a significant lift on your part. For number one, plans are required to publicly disclose a substantial amount of data, including negotiated pricing. Cost sharing information must be readily available to participants via new internet-based tools. Surprise billing of participants for certain out-of-network services is prohibited. Plans must follow the new independent dispute resolution process if agreements cannot be reached regarding those out-of-network provider balance bills. Prescription drug information must be reported to the government. And plans must now comply with a written analysis requirement that demonstrates their compliance with certain mental health parity requirements. So here I've provided you with what I like to call my cheat sheets, because who doesn't like a good cheat sheet? This really is just a timeline of the effective and enforcement dates of all of these various regulations that we're going to talk to you about today. It starts from 12/2020 with the initial removal of the gag clause and the enactment date of the Consolidated Appropriations Act, and we bring you all the way up to 2020-24 when the internet cost sharing tool rolls out for all items and services. I hope you find that as beneficial as I have. And with that, I'm now going to turn it over to Carol, who will begin talking to you about the Transparency and Coverage Final Rule.
Thank you, Lori, so much. That was a great introduction, and I love that timeline you created. I think that is a gem. Going on to the Transparency and Coverage Final Rule, just to review here, 2 basic requirements. We know the first is the public disclosure of pricing data, which should sound perhaps too familiar to everyone. This required non-grandfathered plans to disclose negotiated rates for in-network covered items and services, historical out-of-network bill charges and payments in 90-day periods. Requirement, as we know, is machine-readable files, those MRFs that must be updated monthly. So it's ongoing, the obligation. And the disclosures, and this was really the challenge, must be posted on a public website and accessible free of charge without requiring the establishment of user account or password, basically no restrictions to access. And the point here, of course, was this was a public disclosure, so it was intended for the general public. We're so accustomed to disclosure to participants, and that really wasn't the case here. This wasn't participant directed. It was effective for plan years beginning on or after January 1st, 2022. Enforcement was delayed, so there was a reprieve for plans whose plan years start in the first half of the year, the calendar year plans. I suppose most plans have posted their files, except for our December 1st plans. They still have a few weeks here. The original requirement, just a reminder, was also to disclose prescription drug information. That's pending review because of the similar pharmacy benefit reporting requirement under the CAA. The regulators said they're going to look to see, there's a lot of duplication here. Are those prescription drug MRFs still necessary? So we'll have to stay posted on that. Where are we now? with this first requirement. Are there any new developments? By now, as I said, most plans have posted the MRF for several months, but there was so much initial confusion regarding the posting logistics. By far, the biggest question we received wasn't on the content of the files, but how do we publicly post it? The final rules clearly said it had to be available to the general public, but of course, most employers don't have a public website for their group health plan. Some have a public website mainly directed to consumers, and others had no website at all. So this was the big dilemma. Finally, in FAQs that came out in August, it would have been great if they came out a little earlier, the government provided some relief, and they clarified that if a group health plan doesn't have a public website, the plan could satisfy the posting requirement by entering a written agreement with a service provider, such as the carrier TPA, to post the files on their public website for the plan. So I think that's what a lot of employers are doing now to contract with their carriers and TPAs to post the file on the plan's behalf. What else has been happening? Well, the industry is developing those resources that use that publicly disclosed data to develop tools so employers can compare healthcare items and services. So hopefully these will be of assistance to employers in the near future. And that's, the positive result of all the work. Hopefully we'll all see that soon. What's the second requirement? And this is up and coming, so hopefully it hasn't fallen off the radar. Non-grandfathered plans must also provide participants with personalized out-of-pocket cost information for covered healthcare items and services, and that's through an online self-service tool, and also if requested in paper format. And the disclosure is designed to provide participants with estimates of their cost-sharing liability with different providers before receiving care, so they can better compare costs. The format could be like an explanation of benefits and would include actual negotiated rates, real-time accumulated amounts towards deductibles and out-of-pocket maximums. And there's some other details that we'll be getting into momentarily. But very much the regulators did emphasize that they wanted it to be similar to an explanation of benefits, so the content is also very similar. The information must be provided in plain language and indicate it's only an estimate. And this is effective. It's a phased in effective dates here for plan years beginning on or after January 1st of 2023 for 500 common items and services. I think they were the most commonly shopped for items and services on the sites that are available now. And then all covered items and services, which includes prescription drugs and medical equipment, would need to be disclosed for plan years beginning on or after January 1st, 2024. Was there any new guidance? Well, the initial guidance was in the transparency and coverage final rule with the details of all the disclosure requirements. And I won't go through all these details here. But again, the cost sharing liability and estimate, amounts towards deductibles out-of-pocket maximums, notice of any prerequisites, is prior authorization required, and a disclosure clearly indicating it's an estimate. There's no guarantee of coverage. So there's basically these 7 elements, and the disclosure notice, the plans are free to enhance that if they feel the need to do so. After that initial final rule, there was guidance issued in August of 2021, and here the regulators were looking at this internet self-service tool and a similar price comparison tool that was under the Consolidated Appropriations Act, and said, hey, these are really similar. The main difference between the two is that the CAA tool adds a phone request requirement. So in the FAQs, they indicated they may propose guidance to consolidate the two. We haven't heard any more on that, but perhaps that will be the case, and the request will not only be by internet or paper, but by phone for this internet cost sharing tool. Then in August of 2022, just recently, there was guidance explaining where to locate that current list of 500 items and services for the 2023 plan year. The list is going to be updated quarterly, so that's something to monitor. And there will be time given after it's updated for plans to adopt the new list. So this is a case of be in touch with your service providers, but also stay tuned for additional guidance. All right, so what are considerations now for both of these requirements? Well, for the tool, first of all, you just want to contact your carrier or TPA and make sure the implementation for 2023 is on schedule, and we're getting close, and work with their service providers to prepare participant instructional materials for using the tool. This requirement, that tool is participant directed. Monitor your service providers and guidance, and then ensure your written contracts with carriers and TPAs address the requirement and each party's obligations. And we know, and this is true not only of transparency and coverage, but with the other transparency requirements under the CAA, that basically insured plans can contract with the carrier, and the carrier can agree to assume liability for the disclosures. So if something goes awry, the plan is not liable. By contrast with self-funded plans, they can contract for assistance in meeting these requirements, but they remain ultimately liable for meeting them. And employers may want to engage counsel for assistance with the contracting process. But I do want to really emphasize here, the guidance all says that pursuant to a quote unquote written agreement, and a question we've often been asked is, is an email sufficient? And we really can't comfortably say that. So to the extent that you can, you really want to memorialize this in your service agreements, and engage counsel, because as I said, particularly with a self-funded plan, as far as the regulator is concerned, the plan is always liable. But under state law that your contract is written, there may be some protection, whether it's indemnification or otherwise, that could be built into that contract should your TPA fail to perform. So I'll emphasize that here throughout the presentation. We'll talk about contracts, but just driving the point home here. And with that, we'll go on to some of the CAA transparency requirements. And Lori, I'll turn it back over to you to start with the removal of gag clauses.
Thank you, Carol. Thank you for that nice summary. Moving on to the Consolidated Appropriations Act transparency requirement. There was one provision within the CAA that I'd like to begin with. This one kicked off back in 2020, actually on the enactment date of the CAA, December 27th, 2020. So it's probably safe to assume that many of your contracts have been revised appropriately to ensure compliance here. But if not, it's something to remember. And when going through that timeline that we presented earlier, you might want to make sure you double check this gag clause prohibition and ensure that you're in compliance here. But really what this provided, the law really just essentially prohibits plans from entering into contracts that contain any sort of gag clause provision. Gag clauses, which are provisions that generally restrict plans and providers and TPA from just generally sharing information such as provider-specific cost and quality of care information, and then providing that information to participants or referring providers. Also information such as electronic accessing de-identified participants' claims data that reflects the costs related to those claims. That would obviously be consistent with HIPAA, ADA, and GINA. And then sharing this information with a HIPAA business associate. Again, those are the types of provisions that are now prohibited under this removal of gag clause. I'd also like to point out that the law also requires plans to submit an annual attestation to certify their compliance. However, we haven't received much guidance around this annual attestation. Although in August of 2021, regulators did indicate that they were expecting to begin collecting those attestations in 2022. Again, we haven't seen much guidance around that. Having said that, we advise that you be prepared to submit an annual attestation just to show compliance should a regulator come along and ask for it. Otherwise, stay tuned for updates. The next requirement I'd like to discuss with you has probably created a little bit more buzz than the gag clause removal provision, and that's this non-quantitative treatment limitation written analysis around the mental health parity requirements. So let's start off and kind of go back again in time here. Mental health parity has been around for quite some time. I think most of us on the call are familiar with it, but in general, it requires that financial requirements and treatment limitations imposed on a plan's mental health and substance use disorder benefits cannot be any more restrictive than those that are applied to the medical surgical benefits. And remember, treatment limitations can be both quantitative or non-quantitative. Examples of non-quantitative treatment limitations include pre-authorization requirements, step therapy protocols, experimental treatment exclusions, and standards for provision admissions to a network. So what's new here then, Lori? What are you talking about? Well, the CAA came along and just introduced an additional new requirement on top of this. Now plans must perform and document a written analysis of the design and application of those non-quantitative treatment limitations that are imposed on their mental health benefits as they compare to those treatment limitations imposed on the medical and surgical benefits. In other words, plans must be prepared to demonstrate parity as it relates to the treatment limitations, the non-quantitative treatment limitations on their mental health and med-surg benefits. This written requirement has been in effect since February of 2021, and the analysis and the supporting data are required to be made available to regulators upon request. It's also important to note that subsequent guidance confirmed that the analysis must also be made available to participants upon request, similar to that of a plan document request. So where are we now with this new requirement? Compliance with these treatment limitation analysis has presented significant challenges for employers, especially for self-funded plans. Requirements are detailed. They include review of each non-quantitative treatment limitation and related factors, including evidentiary standards, strategies, and processes to ensure parity, not only in design, but in actual operation. And that's an important point to remember here. This written analysis is not something that you can rely on the design within your plan, but you have to be prepared to show parity in actual operation and administration. We understand that employers largely rely upon your TPA for their plan design, and you're not going to always have the necessary data needed to complete this analysis. So you need to reach out to your TPA and confirm that they're able to do this. And if they're not able to provide this written analysis, then you need to probably think about reaching out to a law firm or a third-party vendor to help assist with it. Furthermore, the DOL has not yet issued a sample analysis or any other further guidance around this regulation. So it's difficult to know whether your TPA or other vendor is actually preparing it adequately. And unfortunately, we do know the DOL has made mental health parity an enforcement priority. The DOL recently requested and reviewed the written non-quantitative treatment limitation analysis for numerous plans. And what was the end result? Well, we learned that not even one plan satisfied these new requirements. Every plan failed. We also learned from that exercise that the non-quantitative treatment limitations that were most commonly found to violate this new requirement included pre-authorization requirements and limits or exclusions for ABA therapy and other services related to the treatment of the autism spectrum disorder. As a result, we highly recommend that employers consult with counsel if you wish to continue to maintain any sort of ACA therapy exclusion in your plan design. So what should you do? Well, first and foremost, contact your insurer or TPA if you haven't already to ensure that they can prepare this analysis. And if they can, request that one be completed for you to review. Ensure the plan has written NQTL analysis to provide to a regulator upon or participant upon request. It's also important to note that insurers are also subject to this requirement. So analysis for fully insured plans is probably easily available. However, for self-funded plans, the plan is ultimately responsible, and you're likely going to need assistance from a TPA. And if your TPA, again, cannot prepare it, then be prepared to screen possible vendors to assist with this exercise. If the carrier TPA agrees to provide the analysis, make sure you're considering the contract obligations within those ASOs. Make any necessary updates to ensure that they're assuming those obligations. Also, educate yourself on problematic plan provisions and the non-quantitative treatment limitation analysis requirements. Take advantage of the DOL resources, including the new mental health parity self-compliance tool found on the DOL website. Review the treatment limitation terms in your current plan documents and ensure plans analysis provides detailed and reasoned explanation for compliance for each treatment limitation, and make sure it's supported by data. Establish procedures for ongoing compliance, including participant requests. Remember, we now know that those are subject to ERISA disclosure requirements. And of course, consult with counsel and stay informed on further DOL guidance. It's also important to note that there are pending legislative proposals that will allow the DOL to more directly regulate the activities in TPAs and may even give them the ability to assess civil penalties directly on insurers and TPAs. And with that, I'm going to turn it back over to Carol, who's now going to talk a bit about the pharmacy benefit reporting requirements.
Thank you, Lori. That great update. And as if the mental health parity analysis wasn't challenging enough, we're now faced with the pharmacy benefit reporting, which I think has also been challenging thus far for many employers, again, particularly your self-funded ones. So let's just review here. We know that group health plans and insurers are required to submit some significant amounts of detailed data, not only about prescription drugs, but also about healthcare spending in general. And presumably that's because they're looking in this report that our government is going to come out with biannually to do a comparison of, the cost of prescription drugs as compared to overall healthcare spending. After delayed enforcement, the 2020 and 2021 required data, its calendar years, they're called reference years, is due by December 27th, 2022. The subsequent reports are due annually by June 1st. The regulators have released interim final rules in November of last year to implement these reporting requirements. And the data has to be submitted in specific files through the CMS prescription drug data collection portal. They provided reporting instructions. It's expected that employers will coordinate and contract with insurers, TPAs and their PBMs and other vendors to submit most required data on the plan's behalf. Most data can be aggregated on the state and market level. Market, for example, would be a fully insured small group plan. And the government, if you read the regulations, actually emphasizes, that they really, they seem to really encourage the information to be submitted in the aggregate. The challenge is, of course, is that the government really doesn't have, isn't able to really regulate the TPAs. So in some cases, employers may need to submit data files directly to that CMS designated portal. Regulators will review and compile this information in de-identified format into a publicly available report that looks on, and this is really on a national level, prescription drug reimbursements, pricing trends, and the role of drug costs in contributing to premium rates. The first report is expected to be released in late June 2023. What information must be reported? All right, we're going to have to get into the details. It's almost impossible not to, because I think the questions come up and, there's always a reference to the D1, the D2 file. So let's just take a quick look here. What information must be reported? And the data has to be submitted on the specified template for that purpose. So for group health plans, there's a P2 that's really an identifier, identifying the plan and certain plan-specific data, such as the plan year, participant counts, and stage in which the coverage is offered. The D1 and the D2 files are, the D1 has certain information also about premium and life years, average member count throughout the year, premium or premium equivalents, stop loss premium paid, average monthly premium amounts paid by the employers and employees. And that's something only the employer may possess in many cases. And also any ASO or other TPA fees paid. The D2 file is spending by category, the total plan spending by service type. So the D1 and D2 files are generally the medical plan information. Then we get to the D3 and the D through D8 files, and these will really be the pharmacy benefit. So the PBM is likely to have this information. You go through it quickly, the topmost 50 dispensed brand prescription drugs, the total paid claims for each, the plan's most costly drugs by total annual spending and the amount spent for each, the 50 drugs with the greatest annual cost increase and the amount of change of each, the drug totals, the rebates by each therapeutic class, and the rebates for the top 25 drugs. So employers, to the extent they can, would certainly would want to arrange with the carriers and vendors to submit the data for the plan. They're not required to, but I think most certainly want to. The carriers and TPAs would submit the D1 and D2 data for the medical plan, and the PBMs would submit the D3 through D8 data for the pharmacy benefit. Employers may need to provide certain information, like I said, for example, the premiums paid by employer and employee. What should employers do now? Well, first of all, determine which benefits are subject to the reporting requirements. We know fully insured and self-insured group health plans, including state and local government and church plans, must report. And then there are exceptions for account-based plans, such as your HREs and accepted benefits. Maybe a clinic, certain EAPs may fall into ACA accepted benefit category, disease-specific plans, fixed indemnity, they'd be exempt. But I think you really have to take time with this first step, because there's a lot of point solutions and other benefits, and there's always that analysis: is it a group health plan? And if it's a group health plan, then the reporting requirements arise. So I think employers really need to take stock at that first step, like which plans of ours, which benefits are subject to these reporting requirements. And then identify which insurers or vendors have the necessary data for each of those plans. For insured plans that don't have any carve-out programs, the carrier will normally possess most of the necessary data. That may be straightforward for an insured plan. For self-insured plans, the required data may be possessed by the TPA, PBM, and possibly additional third-party vendors. You'd want to contact the insurers and TPAs and vendors as soon as possible to determine whether these parties will submit the required data on the plan's behalf. And if the carrier TPA will also submit the plan-specific data with the aggregated data, so the employer doesn't have to file anything directly. If so, meet any deadline that they ask you to meet to provide that data. If the TPA, PBM, or other vendor will not submit the required data on the plan's behalf, then the employer needs to do so directly. And this, according to the instructions, this requires an account with the health insurance oversight system. CMS has produced RxDC and portal user manuals that they address the account creation and the registration process and the technical submission requirements. But IT support will likely be needed for the submissions. And there's also been requests for CMS to produce some training and more guidance here on the technical aspect, because they're really the only party that can do that. Their system and employers just aren't prepared, most of them, to submit this type of data. So hopefully we will see some more training, and soon. Continuing, what should employers do now? Certainly work with your counsel to ensure, work with your counsel regarding the whole process. I mean, you have to identify the plans, make sure you're submitting the right data, but also to ensure that those agreements are updated to reflect each party's obligations. And I'm just going to emphasize the last bullet point here. You want to, when you enter a contract, make sure that the vendor is going to be willing to provide the information, when you switch vendors, because the reporting is always for the prior calendar year. You want the TPA to agree to cooperate and report or provide the necessary data for their period of service, either directly to your current TPA or vendor, or directly to CMS. So I think that's something to keep in mind, because we're always going to be a year behind with this. You want to, going into a contract, make sure you have their cooperation when you have that negotiating power. Request a copy of the submitted data and confirmation of timely submission from the insurer TPA. to my knowledge, there's no way an employer can confirm when these other parties have submitted on their behalf. Maybe that will change, but you do want to request some type of confirmation so that you have it for your records. Monitor for additional guidance here. CMS, as I said, has released numerous instructional guides, and then they've updated them. So they have clarified some of the issues and questions. I think they're really trying to address things. So it's always important to make sure you're looking at the latest guide. Go to their website directly. Industry groups and ones we participate in has specifically asked for good faith compliance relief. It's clearly recognized employers are struggling to meet this requirement. And unfortunately, unlike other provisions of the CAA, we don't have good faith compliance relief. So that's one thing that's been requested. Also, a 30-day grace period after December 27th to submit the files. Clarification on outstanding reporting issues. As I mentioned before, a CMS technical assistance and training. So employers should reach out now to coordinate with their service providers and stay tuned for updates. Unfortunately, we've been asked about penalties. The rules, I always concerns me when I hear that question. The rules don't specify penalties. However, if it's the normal framework, the DOL would enforce for ERISA plans, and there could be a penalty, an IRS penalty of $100 per participant per day for failure to meet a group health plan requirement. So you don't want to throw up your hands in the struggle. You certainly want to take steps and document what you're trying to do. Okay, now we're going to switch gears a little to go to the No Surprises Act and the surprise billing prohibitions, which took effect earlier this year. And now we're starting to receive questions. So I think it's a good time to review what's covered, what's not, and also the court case involving the IDR process. So the surprise billing, the No Surprises Act, was largely designed to address balance billing when out-of-network providers bill a participant for the difference between the provider's bill charge and the amount collected from the plan plus the participant cost sharing. Provider's charge is $1,200. Plan's allowed amount and cost sharing is $700. The provider may bill the participant for the remaining $500. Typically, this arises in an emergency setting, but it can also arise when you schedule a procedure with an in-network facility, and then there's some type of out-of-network provider, a radiologist, an anesthesiologist, unbeknownst to you ahead of time. And then the participant receives this unexpected and often costly bill. So the surprise billing prohibitions were designed to protect consumers and put downward pressure on prices. And as Lori mentioned earlier, previously there was no means to address these type of charges on a national level. So what services are covered? Let's review here. Emergency services, we have this expanded definition from the ACA. So it's defined broadly to include medical screenings, even certain ancillary evaluation services, stabilization, and certain post-stabilization services. And emergency services include services not only in an emergency department of a hospital, but also an independent freestanding emergency department that would normally be licensed by the state. Air, but not ground ambulance services provided by out-of-network providers. And that's counterintuitive. That surprises most people. My understanding is the reason for that is that there's different parties, so many different parties, private entities, sometimes municipal, nonprofits providing these services that the government couldn't come up with a law that could regulate all of them for the ground ambulance services. But I understand there are committees looking into that now. So maybe we'll see that included in the future. And also certain non-emergency services, as I mentioned, provided by out-of-network providers at an in-network facility. How are participants protected? The participants' cost sharing for any of these protected services are limited to in-network levels based upon what's called a recognized amount. And we go in order. Is there an all-payer model agreement? Very few states have that. That's an agreement with the federal government that really sets the price for the provider for a particular service for all the patients. The state surprise billing law generally apply to insured plans. There are a good number of states that have these laws. Some do allow self-funded plans to opt in. but mostly we're talking about insured plans. And then otherwise, the lesser of the bill charge, it's known as the qualifying payment amount, QPA. And QPA, remember that term, it's going to come up again. It's the median contracted rate for the item or service in the geographic region. So if we have the sequence of numbers 20, 40, 100, 40 is the median. It's not an average, it's just the middle. Participant cost sharing must count towards any in-network deductible or out-of-pocket maximum, and participant balance billing is prohibited. So let's look at an example. We have Joy. She's enrolled in an HDHP with a $1,500 deductible, which she's met. She hasn't met her out-of-pocket maximum. Her co-insurance is 20%. She receives emergency care in an out-of-network hospital, and she's billed $1,800. And she's in State A. State A doesn't have an all-payer model agreement, right? We're going to 1, we X that off. Doesn't have a state balance billing law, so we can't use 2. So now we go to 3, right? The lesser of the bill charge, or QPA. So the QPA is $1,000. So her cost sharing is the lesser of the bill charge, which was $1,800, or the QPA, $1,000. Joy pays $200, applies to her out-of-pocket maximum, and her obligation's done. So the plan must address now that remaining $1,600. So what about, does the plan pay to this out-of-network provider, right? We have an out-of-network provider who wants, I believe he's entitled to $1,600. The plan's cost sharing is based upon, again, the same, the all-payer model agreement, state law, extent 1 applies, or step 3 would be an amount agreed upon by the plan and the provider or facility. And if none of those apply, then the amount selected by a certified independent dispute resolution entity. So there is, we won't get into all the steps, but the parties are required to enter a 30-day negotiation period. And once that is exhausted, then either can initiate this IDR process. So most of your self-funded plans are going to, if they can't reach an agreement, they may have to resort to using this process. I mentioned on the bottom, there's a chart that I think is helpful, CMS has come out with, to explain like which plans are using the federal process, the state process, or a bifurcated process. Bifurcated happens a lot. That means the state law covers certain items, but not all, because the federal surprise billing law is more expansive. So maybe certain items are covered under the state law and certain under the federal process. Have there been any developments with this IDR process? Yes, the Texas court case, Texas Medical Association versus HHS, the physicians sued HHS over the rule governing the IDR process. And this was one of half a dozen cases brought by physicians. Under this interim final rule, when deciding first of all, the arbitrator, that certified IDR entity, in this process, they're required to select one party's offer as the out-of-network payment amount. They're not looking to come up with something in the middle. It's got to be one party's offer or the other. So under the rule, when deciding the payment, the arbitrator was supposed to presume that the QPA, again, we said that was the regional contracted rate for the item or service, in our example, $1,000, with the appropriate amount, unless there was credible information that the value was materially different than the QPA. So the physicians in this case and the others challenged that and said, no, that's inconsistent with what the CAA, NSA, the statutory language actually said. You've exceeded your authority here in making this rule. And they said, under the NSA language, there has to be equal consideration of that QPA, but also other factors, such as the provider's level of training, their experience, their quality, the acuity of the patient, and the complexity of providing that patient with care, the market share held by the providers, demonstration of good faith efforts to enter a network agreement, and then any other credible evidence. You can see these items under consideration. In many cases, they may raise the value, higher than what the QPA with the contracted rate for the region is. The court agreed with the physicians and struck down key parts of the rule and removed that QPA presumption. And HHS responded by issuing a final rule and then also modifying other guidance based on that court ruling. So the bottom line here is that although we don't know the ultimate effect yet, the main concern now is that the outer network provider payments determined through this process are going to be higher than originally expected under that rule, and it could raise the plan costs because there's no longer really that pressure for a provider, let's say, to submit a payment offer that's close to the QPA when they take these other factors into account. What other updates are there? Are there any updates to the notice requirements? And yes, by the first day of the 2022 plan year, we know that plans are required to post on a public website a notice. This is explaining surprise billing prohibitions and how they'll impact medical billing, state law protections, and also agency contacts to report violations. There was some confusion on what the public website was all about because it would seem this notice is directed to participants. In August FAQs, the government clarified that if the group health plan doesn't have a website, the requirements can be met. Again, if the plan enters an agreement with the insurer or TPA to post this information on the public website for the plan, where it's normally made available to participants. The plan remains liable for a failure to post. We'll just note here, there's an updated model notice for plan years beginning in 2023. So just take note of that. You're not required to deliver the notice to employees, but you may opt to, since it is really directed towards them, you can include it if you wish with other benefit materials. What should employers be doing now? Certainly educate yourself on the surprise billing protections. Questions are starting to arise. Communicate, obviously with your carriers and service providers, especially regarding the notice posting. Amend your contracts. Update your plan documents and SPDs as necessary to incorporate the new rules. You may need to expand the emergency services language and, cost sharing terms. Monitor the impact on plan costs, especially after that court decision, and for any other regulatory updates. And with that, I am going to turn the presentation back over to you, Lori, to discuss some other provisions under the CAA.
Oh, thank you very much for that, Carol. That was a lot to cover, and you did a great job at summarizing those requirements. I hope we have time. Here, I'm going to try to cover these last few requirements, and we should have enough time to take some questions regarding any of that. These last few requirements I want to talk to you about under the Consolidated Appropriations Act. I want to start by reminding folks that these provisions are either pending final rules or are effective, but plans can rely on good faith effort to maintain compliance. We did want to mention them because we do anticipate some movement on some of these at some point in the future, at least on this very first one. And this is the air ambulance reporting requirement. Under the No Surprises Act, plans and insurers are required to disclose certain data to HHS regarding their air ambulance services. Under a September 2021 proposed rule, reporting for the 2022 plan year is due by March of this next year in 2023. And for every year thereafter, the previous plan year would be due at the end of March thereafter. For each air ambulance claim received or paid, the report needs to include information such as plan identification information and coverage type, i.e. whether you're large or self-funded, fully insured, service date, transport information such as aircraft type, miles, pickup, drop-off zip codes, and whether or not the transportation was for emergency services or not. Whether the provider had a contract with the plan, whether the claim was paid, denied, or appealed, and the denial reason and appeal outcome, just in general, how the claim was adjudicated. And finally, payment information, including submitted charges, plan payments, and any cost sharing amounts. Again, I just want to remind folks that this rule is proposed. If finalized sometime in the near future, reporting could be due as soon as March 31st of 2023. So we advise that you contact your insurer and or TPA to ensure that they are collecting the necessary data needed to complete this should we see a final rule. The next requirement I want to talk about is the advanced explanation of benefits requirement. This requirement, unlike the air ambulance reporting requirement, is only in the RFI phase, the request for information phase. So again, not yet in effect, but I do want to talk about it because it's an interesting one. And that is because this requirement requires plans to provide participants with an advanced EOB for services scheduled at least 3 days in advance or upon a request of a service. Providers would give the plan an estimate of the anticipated charges, and then the plan would provide that advanced EOB to the participant. And that EOB would include information such as the provider's network status, the contracted rate for an in-network provider, or if out-of-network estimated charges, cost sharing obligations, and year-to-date deductible and out-of-pocket information. The EOB would provide participants with an estimate of their cost sharing obligations with specific providers prior to receiving care. Again, enforcement is delayed while the regulators continue to determine the implementation process. And there's been a lot of concern around the implementation process, a lot of privacy concerns. So we don't believe a final rule is imminent due to these technology and privacy concerns, but we did want to bring your attention to it anyway. The final reporting requirement under the Consolidated Appropriation Act, there's actually a few here, and most of these are probably have already been implemented, but we just wanted to mention them, and those include the continuity of care provisions, insurance ID cards, and changes made to provider directories. Again, these are in effect. Employers should be in compliance by demonstrating good faith efforts. Let's talk about continuity of care. Good old common sense requirement in that if a contract is terminated with an in-network provider, participants that are currently undergoing care for certain serious and complex conditions can elect up to 90 days of continuing care with that provider at the same in-network level terms and conditions. Again, these provisions have in effect for the entire 2022 plan year, and employers are expected to be in compliance, demonstrating good faith. In addition, insurance ID cards. The physical and digital member ID cards must now reflect any plan deductibles, out-of-pocket limits, and of course, phone number and websites for further assistance. And finally, changes to provider directories. Plans must now maintain an accurate and current directory of in-network providers on a public website. However, now updates must be made within 2 days of notice by providers. And participant requests about a provider's in-network status must be answered within 1 business day. And that's it. But to summarize quickly for you, the Transparency and Coverage and Consolidated Appropriation Transparency and No Surprises Act provisions do indeed impose significant obligations upon group health plans. Plan sponsors should consult with service providers and their outside counsel to ensure ongoing compliance with these requirements. In addition, you may need to look over your service provider contracts to ensure that any updates are included, especially as they relate to obligations. Upcoming new requirements include the Transparency and Coverage Cost Sharing Tool and the Pharmacy and Healthcare Spending Report that Carol just talked about. We also need to look at our plan documents and any communications with participants and need to evaluate on whether or not changes need to be made, reflecting any changes to plan design. Finally, stay tuned to regulatory updates and enforcement initiatives. As always, watch your inbox for updates to the NFP compliance newsletter and or our Washington updates. We have included a final slide here for you that mentions some of the resources that we've cited throughout the presentation. I really like the mental health parity self-compliance tool that you can find on the DOL website. It generally provides just good best practices for internal compliance strategies. My understanding is that it offers like these warning signs that alert plans to different areas of concerns that may need additional review. But all of these resources can be found here on this website. The links to their websites can be found right here on this final slide that we will be distributing post-presentation today. And that is it. I have not been monitoring the chat. Are there any questions? It looks like we do have just a couple of minutes.
Hi, thank you so much. First of all, Lori, hey everyone, this is Jill. Lori, is this your first time on Get Wise Wednesday?
It is on a Get Wise Wednesday call.
Oh, welcome. Love it. Yeah, so if you guys are not familiar with Lori, she's been on our team for a long time, but she is in the West Coast region and specializes over there and does a lot of different things. So thank you for helping us today understand all of this. Yeah, we got some good questions. So everybody look through the chat and look through the Q&A section. I do want to say we did just an informal poll in the chat, and we had both fully insured and self-insured clients report back that they had received communication from carriers and TPAs, and they are having to do P2 and D1. And that was from fully insured and self-insured. So I thought that was interesting. Yeah, on the pharmacy reporting. So, and then we had some that said that they had not heard from their carriers yet. So again, this requirement on the pharmacy reporting is due at the end of December. And so if you have not heard from them, ping your consultant, your NFP consultant, and they may know what your specific carrier is doing, or they can at least find out what you need to do. And if you are going to have to do some of this pharmacy reporting, yeah, you'd have to register on that site. But as Lori put on that last slide and went over, those were all the publicly available resources, either in Compliance Corner, our publication, or the DOL tools. We also have some publications that are available to you through your consultant. And those, we have a lot of those topics. There's a transparency white paper that Carol wrote. We have a mental health parity paper. So anything that you want additional information on, please let your consultant know and we can find out the answer for you. So thanks so much to you and Carol for your assistance today. It's a tough topic, and you made it really easy to understand. The slides will be sent out to everyone who was registered for this webinar, so you will get those along with the recording. So yeah, just keep reading Compliance Corner, keep going to nfp.com and getting those public resources. So again, you should have already done something about the machine readable files. You should have done something with your no surprise billing notice, and you should at least know what's going on for December. And if any of those things don't sound familiar to you, get with your consultant. Amber, I will turn it back to you.
Thank you. Thank you to our speakers for sharing your valuable time and expertise with us today. To reiterate, today's presentation has been recorded and will be following up via email in the next few business days. You will also receive a copy of the PowerPoint slides used during this presentation. At the end of this call, a survey will populate in a new window. Please take a brief moment to complete the survey, as it lets us know what topics are important to our listeners and helps make our education program as current and relevant as possible. That concludes our webinar for today. Thank you, everyone, for joining us, and have a great day.